So what we've been doing in Amsterdam are two studies, one with targeted therapy upfront in the neo-adjuvant setting and one with a combination immunotherapy with Ipi and Nivo. And certainly the latter one has very exciting results to mention already, because we're seeing a high response rate of 80% in those cases, where the combination for stage 4 has a response rate of about 50 to 60%. But also now, intriguingly, we're seeing long-term benefit of this combination, where you would expect these high-risk stage 3 patients to relapse quite quickly, within 1-2 years, about half to 70% of cases. And certainly for the complete responders, we have seen 0 relapses, but also for the partial responders, the chance of relapse seems to be very much reduced. And we're very hopeful that we're increasing the cure rate now with this new approach.
Which I suppose, if there is, like you say, this tremendous response and long-term benefit, how much room does that leave for any surgical intervention as a follow-up, or if it's even necessary?
Yeah, so that's a very intriguing question. What we're also examining now is, because we're still doing the full lymph node surgery on these cases, is if that is really necessary, or if there are other ways to measure the response. So we're using the CT scans now with the RECIST criteria to look at those responses, but they're not correlating with the pathologic response yet. So we're moving towards other ways of assessing this. And for one thing we've been doing in breast cancer at my institution is taking out an index node and examining that index node. If that index node is then clear of disease, it correlates really well with the rest of the lymph nodes, and you can save the patient unnecessary extensive surgery in those cases. So we're now doing that with a magnetic marker, which is also not a radioactive marker, which we are using in breast cancer, which also takes away the risk of radiation, which might not be applicable to all institutes.
Let's have a look at what's happened so far at ESMO, something that's come out, anything that's caught your attention over the last 2 days.
Yeah, so for the stage 4 disease, there was on Saturday some nice presentations on, for instance, a new combination of epacadostat with pembrolizumab for stage 4 patients, which showed very nice response rates, but also a very good safety profile with less adverse events than the combination of Ipi and Nivo. So I think that's something really to look forward to, the phase 3 data, which will eventually come out of that study.
And for, like you say, the upcoming data from the Monday trials and your own research, shall we keep an eye out for those in the near futures for any skin cancer congress? I think the next one's in Australia.
Yeah, so the next one will be indeed in Brisbane, the SMR. I don't think there will be any landmark new things coming there, but certainly in the first or second quarter of 2018, the adjuvant pembrolizumab study will also be released, and there's an ongoing study now with a combination Ipi and Nivo in the adjuvant setting, which is still accruing, so that will take some time still.
Okay. Well, I think that covers what's been and what's coming up. Is there anything else that we didn't get to mention?
So another interesting thing for surgical oncology on melanoma is the ongoing study of the combination of T-VEC, which is an oncolytic virus, with pembrolizumab. That study is expected to complete the accrual by the first quarter of 2018. So certainly for me as a surgeon, for patients with intransit lesions, that is something I'm very much looking forward to. And already from the phase 1 presented at the ASCO this year, there was some nice signs of a beneficial impact of the combination. And also just last week, Tony Ribas published in Cell a nice paper on this.